Good evening, everyone, and welcome to CaraConference 2020, HIV Now and Next. I'm Adam Riley. I'm CaraCol's Testing, Outreach, and Education Manager, and tonight's evening program was made possible through a partnership with MATEC, the Midwest AIDS Training and Education Center through the University of Cincinnati. We will be providing CMEs for tonight's session. Before we get started into our presentation, I have a few housekeeping slides that I'm going to cover. CaraCol is Cincinnati's comprehensive AIDS service organization with a mission to positively change lives in the fight against HIV. You can find us at caracol.org or on Facebook, Instagram, Twitter, using the handle We Are CaraCol. And if you're feeling social tonight, please share and use the hashtag CaraConf. If you have questions related to tech issues, please use the chat function. And if you have questions related to the content of this evening's program, use the Q&A function. We'll have somebody monitoring both of those functions and we'll be able to get questions to the presenter. At the end of today's presentation, you will be prompted, you'll get a link that will prompt you to a survey. This survey is just for feedback on tonight and how you thought it went. Please complete that survey. We value any and all feedback. You'll get an additional evaluation that is attached to your CMEs via email from MATEC this evening. So there's two surveys, one just kind of on how tonight went, and then the other one is attached to your CMEs. And with that, I am going to hand it over to Linda Sider, who is CaraCol's Executive Director. Linda?
Thanks, Adam. Sorry I had some technical difficulty as well. So first of all, I want to welcome everybody and good evening. So welcome to our third annual CaraConference presented by CaraCol, as Adam said, Greater Cincinnati's AIDS Service Organization. And I'm Linda Sider, the Executive Director of CaraCol. We had hoped, of course, to do a full day conference like we've done in the past. And we've not been able to do that, of course, because of COVID. Who would ever thought last year when we started planning this conference that it would be virtual, but that's the world we live in, right? So although we're disappointed not to be together in the same room tonight, we hope that this experience will still provide you with the high quality education and interaction that you have come to expect from CaraConference. So thank you for being here. This is the first year, as Adam mentioned, that we've been able to provide CMEs, and thanks to our partnership with UC's MATEC. Our special thanks goes to Ashley Klunkmore at MATEC for her efforts to secure our speaker and CMEs for the evening's program. So PrEP is an important part of ending the HIV epidemic, but many in the Cincinnati area, many providers have limited access to the information about PrEP to meet the needs in our community, and that's why we're here tonight. So tonight we hope to remedy that. We hope that with this training, we will help increase availability of PrEP in our community and to teach you what you need to know to confidently address PrEP with the patients that you see. Today's presenter is Dr. Ann Avery, an associate professor of medicine at Case Western Reserve University and practicing infectious disease physician at Metro Health Medical Center in Cleveland, Ohio. So thank you for being here, Dr. Avery. And our moderator tonight will be Adam Riley, CaraCol's Testing, Education, and Outreach Manager. He will help to field questions during the session. Again, welcome and thank you all for being here.
Hi, everyone. It's a pleasure to be a part of the CaraConference. I was looking forward to coming to Cincinnati, so hopefully next year it's an in-person meeting and I can make it down, if not just to enjoy it. I'm going to try and share my screen, which we tested earlier and it worked, but let me get the right view up. Now, I need to share it now. I don't think I'm sharing the right version. Hold on. We practiced this. It worked before. All right. I think I have the right screen up. Can you all see the title slide?
Yes, it looks good.
Okay, great. All right, so I was asked to talk about PrEP. And so when I think about PrEP, I think about it's really advances in HIV prevention. It's not just prevention for someone with HIV, it's all of HIV prevention. So why did you not move forward? There we go. I have nothing to disclose. And these are learning objectives. I am going to go deeper than these learning objectives, but these are the things that I hope to ensure that you are very knowledgeable about. So CDC recommended guidelines for HIV testing, which I think everyone in the audience is probably already very aware. Being able to determine what patients are appropriate for PrEP therapy, being able to identify side effects of PrEP, and then also be able to describe the required monitoring. The deeper dive is looking at some of the new options for PrEP, as well as for things that are in the pipeline, and complicating situations, things that may not be straightforward. So first, in order to think about HIV and prevention, it's important to look at what we've accomplished. There has been a decline in HIV infections between 2008 and 2014. And importantly, those are among the highest risk groups. So we're seeing a decrease in injection drug use, or new infections among injection drug users, or people who inject drugs, as well as heterosexuals, men who have sex with men, as well as men who have sex with men who are in the youngest age group. So those four groups are experiencing decline. I think others are as well, but those have the greatest reduction. So I went online to the Ohio Department of Health Surveillance, and I updated this slide. I usually have this as Cuyahoga County, where I'm at, and I think it's important to look at where are we as a community. And so the Hamilton County community is not seeing that reduction in cases. And I know that it's been complicated by the opiate epidemic, and injection drug use is not decreasing as a risk factor for HIV. At least it had not been probably at this time of the slides. But it's important to know where we are. And so how can we get the total number of new diagnoses to decrease for 2020 and 2021? And hopefully by the end of this presentation, you'll have some new tools on how to address that. And I think that this is something that I find very motivating, that if San Francisco, which has many more patients and people living with HIV to begin with, as well as people with risk factors for HIV, if they've been able to decrease their new diagnoses from over 500 to nearly 200, which is about what we have in Cleveland, then we can do this too. And the way they've done this is through being very intentional at looking at testing, at treatment, and at prevention. And we have to look at all of these things in order to really move the bar with decreasing new infections. So we've had a really exciting paradigm shift in HIV prevention in the last few years. One of those keys is treatment as prevention. So we've always known in our heart of hearts that treating people with HIV decreases the chance of passing it on. But now we have hard science to show that getting patients on HIV treatment works as good as everything else we have. PrEP is highly effective, and we'll talk a lot about that. And then within PrEP, there are some really good developments that are in some ways taking from the contraception world, but also from other, just a real appreciation for the need for different formulations and delivery mechanisms and long-acting medications, as well as a renewed interest in post-exposure prophylaxis. So all of this led to an announcement from CDC in 2014 that condomless sex does not equal unprotected sex. So a person can be protected from HIV by using PrEP or having a partner that's undetectable. And then I think we also have to continue to look at the social determinants role in HIV and HIV acquisition, because it does continue to be a disease that disproportionately affects our poorest population. So I'm going to briefly touch on antiretroviral-based prevention. I know it's not really what I'm supposed to, but it's part of my nature. I have to, because ARV prevention, as you can see from this slide, is not just treating positives. It is using antiretroviral or biomedical options to use prevention. But the first few things we're going to be looking at is treatment. So this is an old slide, but it still really conveys a great message of looking at how high a person's viral load is and the estimated number of infections that they would be able to pass along based on their viral load. And so individuals with high viral loads have the potential to pass on a much higher number of to a much higher number of people than if they have a low viral load. And this predates all of the U equals U material, but again, I think it's a good visual. So when we think about treatment as prevention, we go way back to the pediatric ACTG trial of 076, which was this landmark study that showed when we gave women who were pregnant and living with HIV a single infusion of AZT, we decreased the risk of mother-to-child transmission of HIV from 28% to 8%. And that led to the decision that all pregnant women need to be getting tested for HIV because we have an intervention that can help. And this really should have got us thinking more about treatment as prevention for everyone, but it didn't, I think, immediately. And so now what we can see among the peds population is for women that are treated, or because of women being treated while they're pregnant, the transmission perinatally, especially in the United States, is extremely low. So we know treatment as prevention works for mother-to-child transmission. But we also now know that being undetectable as an adult individual makes that person untransmittable. So U equals U, and this is important for all the people we know and you talk to understand, because I think this not only helps engage people in getting into their HIV care, it also helps destigmatize HIV. And this has led to guidelines that all individuals living with HIV ought to be on treatment because we know that the medication will reduce the viral load in both the blood and the genital fluids. And the two key trials that led to these very strong statements of undetectable as untransmittable are listed there, the partner study and HPTN 052. So Dr. Fauci, who we all love and hold near and dear to our heart, especially now with COVID, but even for the HIV world, I mean, he's an amazing man. And so he has this, after the HPTN 052 study, just the crystal clear that we can say if you're undetectable, you're untransmittable. And in fact, we can tell patients and do tell patients they don't have to wear condoms for their partner from an HIV prevention standpoint if they are undetectable. The challenge is, as you are probably also very familiar with, that we don't have the majority of individuals on HIV treatment and suppress. This is the original slide that came out, the care continuum, where we were at about 35%, and it's been updated. So just over half of individuals living with HIV are reported to have viral suppression, and this varies certainly in different parts of the country. When we've looked at Cuyahoga County, we're somewhere in this 60 to 65% range, and we certainly want to get closer to the 90-90-90 goal. So I have a case for you, just to get you thinking. It's a 32-year-old man who presents with fatigue and a rash for about 2 weeks. He reports having one sexual partner during the last 6 months, and he uses condoms most of the time. He gets a HIV test that is negative, or non-reactive, and he has a syphilis test where the IgG is reactive, and his RPR is 1 to 64. So we're going to pull up a poll and see what would be your next steps. So Adam's going to pop up a poll and make sure that you guys stay awake while you're eating dinner. Maybe Adam's going to pop up a poll. There, he got a poll. So you may select more than one answer. I can select all that apply.
We're getting some votes in. We'll just give it maybe 30 more seconds and we should have everybody.
Perfect. Your vote will not be linked to you. Don't be afraid.
Okay, so I'm going to go ahead and end this poll and I'm going to share the results with everybody. You should be able to see that now.
All right. So all of you wanted to get more STI testing. That is excellent. More than half of you wanted to also treat the syphilis, which is also excellent. And 3 out of 7 wanted to start Truvada. So the trick part of this is that all of those answers are actually what I would recommend doing. So this person has a positive syphilis test with a positive IgG and a positive RPR and a rash. So they have secondary syphilis and they need treatment for that. Now, we know that so with any STI, we also want to look for other STIs because they like to travel in little packs and hordes and orgies. So 3-site screening is appropriate for this person with secondary syphilis, treatment for secondary syphilis. And then as a result of having syphilis, I would put this person in a very high risk category for HIV because most of the syphilis, at least that we see up here, includes an HIV exposure. So syphilis has been recognized as a sentinel event or very high risk exposure. And I think one kind of easy thing we can do is actually be looking for easy ways to identify individuals. And there was a question about doing swabs because Leanne can't get urine. We are still doing urine. We are actually having a delay in our processing of STI tests because of COVID, but I think that's a national problem because of the tips that the machines use are also used in COVID testing, at least in our institution. So we are able to get the urine done, but it's taking a few more days than we would like for our results to be available. So PrEP. So Truvada is kind of the oldest option for PrEP, and PrEP refers to a pill or a biomedical option to prevent HIV. So slide advance. So PrEP is a great tool and it's very powerful. And part of the reason it's so powerful is it puts the power of prevention into the person who's negative, into the person who's the receptive partner. So potentially a female or a bottom individual. It may in fact enhance the sex and the pleasure because a person is less worried about acquiring HIV, and it may also enhance the pleasure of the HIV positive partner if they know that their partner's on PrEP, or an HIV negative. And just in general, it can increase control control of sexual health, which increases pleasure. It doesn't require your partner's knowledge, so it's controlled. It can be discreet, and it's just a great option. So the CDC has these estimates of over 1 million individuals who are eligible. The majority of those are identified as men who have sex with men, but there are plenty of heterosexual men and heterosexual women that are also felt to be eligible for PrEP. And these estimates, you have to realize, are difficult to make. So who needs PrEP? So there are a lot of the kind of, I hate to say obvious, but the common risk groups that I have at the bottom. But I would also want you to think about STIs. Anybody who comes in with a new STI, particularly a rectal infection or syphilis, has higher risk for HIV than average. If an individual acknowledges having more than one partner concurrently, so we see this at our local health department where someone comes in and they often come in because they have symptoms of an STI and they disclose that they are having sex with the the parent of their baby and their partner. And it might be the mother, it might be the father. We see this both ways. And so that is a concern of a risk factor for HIV. And really anybody who is sexually active and concerned about HIV is a good partner, a good individual for PrEP. I think we don't think about abusive situations, but we've been trying to work with our foster care program more. A lot of the kids in foster care actually identify as a gender minority, either a trans individual or identify as MSM or lesbian. And so those individuals have a higher risk of abuse in the foster care system. And then the things that I think everyone at the meeting is comfortable identifying as a higher risk for HIV: men who have sex with men, trans women, persons who inject drugs, and persons who exchange drugs or money for sex. And this is not exhaustive, but this has got most. So if you want to get really gritty and try and come up with 2 questions to identify who of your patients would be kind of your highest risk individuals and those to most benefit from PrEP, I came up with these 2 questions, and I think I had some help, but I can't remember who. So you could ask, are any of your sexual partners having sex with other people, living with HIV, or injecting drugs? That covers a lot of risk, not all of it, but, and then the second question is, do you ever have anal sex? And I think this is an appropriate question for both men and women. And we'll, just because we can't ignore that women are having anal sex, particularly younger females, where they may still want to protect their virginity or use it as a form of birth control or just for pleasure. But anal sex, regardless of who is having it, poses higher risk for HIV. So again, we had to think about who are we looking for PrEP and who are we testing. So we have to get HIV testing to the community. And I have been pushing locally for many routine testing practices. So we've got prompts in our electronic health record to get everybody tested at least once. We're working to do some modifications to identify individuals who have ongoing risk so that we can increase the frequency of testing. But we know that the lifetime risk for certain groups is higher than average, and particularly men who have sex with men have the highest lifetime risk of HIV still. And that is, 1 in 6 overall for any male who identifies having sex with another male. And then when we break that down into African American, white, or Hispanic, Latino, it's even higher. So the projections from that prior slide actually report that 1 in 2 African American men who have sex with men will develop HIV in their lifetime if we don't do something different. And similarly, the Hispanic are, I think 1 in 4, 1 in 6, and then Caucasian men who have sex with men have the lowest rate, so 1 in 12, which is still really high. That's almost 10%. So this slide just helps guide us where we need to be directing our efforts and our resources, but recognize that, just today I was talking to one of our health department nurse practitioners who had to give a heterosexual female who'd had 2 partners in the past year a new HIV diagnosis. So we can't ignore any group, but we may want to prioritize where we can. So the basics of PrEP is that it's for someone who's HIV negative. So HIV testing is crucial. We have to have an HIV test before starting PrEP, and it has to be given before HIV exposure. So if you've got somebody who just had sex yesterday and they're worried about it, you might want to do an extra test, a HIV viral load or other things, or consider PEP. But in general, it's HIV has to be done, and they need to be negative before they start PrEP. Truvada was the first FDA-approved drug for PrEP. It's not the only one now. It is taken once daily, as is its newer version, which is Descovy, which I will talk about in a moment. And I am such a fan of having every provider comfortable with prescribing PrEP. We've done education to many of our community health practices just because that's where patients are coming in for their prevention, for their primary care. They don't need to come into an ID clinic or see a specialist in order to get PrEP. We can help them manage it if it's a new provider. That's certainly an option. And a good way to get comfortable with a new practice. The thing about PrEP is it's extremely effective when taken daily. For men, it's effective within 7 days. For women, we think it takes a little bit longer, 20 days. The World Health Organization just says 7 days regardless of gender, but the CDC uses 1 week and 3 weeks for men versus women. The other nice thing is it doesn't take 90% effective when taken daily, but we also see that it's pretty forgiving. So there's a question on the chat board from Shanna, and it says, for the first case, she was thinking to wait for a viral load before starting PrEP, and what would be the risk of starting it for a few days while you wait for the viral load? So I actually had viral load in that question initially, and I took it out because this person has secondary syphilis. So depending on the test you're using, which most of us are using 4th or even a 5th generation HIV test, that test should be positive at that point in time. So the window period for the test that we're using in our hospital system is 10 to 14 days. And secondary syphilis occurs at more 2 months to 4 months. So because that person presented with secondary syphilis, I was not as concerned about the window period. However, if you're concerned of a risk, then I would probably wait. If I'm ordering a viral load, I would wait. If I'm concerned enough to order a viral load, I might start combination therapy just to be kind of a bridge and a more safe way to start PrEP in someone who has high risk behavior just right before they start PrEP. Good question. So PrEP with Truvada, which is tenofovir disoproxil fumarate and emtricitabine, is a combination medicine. It is an adjunct to other HIV treatments. So it's part of a highly active retroviral therapy cocktail, but it's not sufficient to treat HIV alone. So the harm of starting it alone is if somebody has active HIV and you start Truvada, they will develop resistance to Truvada, which would be probably 2 mutations, an M184V and a K65R, which would then make those 2 medications not effective for future treatment. So we do want to protect the Truvada by knowing that somebody is HIV negative first. We have a long history of experience with Truvada. It was approved by the FDA for treatment in 2004, and now it's been approved for prevention use since 2012. This is a slide from Rafi Landowitz at UCLA that he shared at one of the Ryan White conferences and made the slides available. And I think it's really fun because you've got a picture of a man and a woman, or woman and a man, depending on which order it is, and the different studies, like what was the population they included, and then also how effective was the medication. And so you can see there is a fairly wide range of efficacy in clinical trials of Truvada for PrEP. So this is our question number 2. The differences in clinical trial efficacy, so Adam, you can pull up the poll, are attributable to which of these factors? You've got 6 options. The intrinsic efficacy between men and women, so anatomical difference in tissue and compartmental kinetics, adherence, absorption, a combination of 2 and 3, or a combination of 3 and 4. So we'll take a minute to let you answer. And again, your answers are not tracked to you, so don't worry. All right, we have answers?
We do. I'm going to end the poll and then share the results.
Excellent, thanks. All right, so the answer is adherence to medication. It does seem like there is some biologic plausibility for differences in compartment or differences in efficacy, but that has not been shown in in studies. So when we look at adherence, it is very closely tied to efficacy. And it's interesting because the way they can do this is they actually will do sampling of individuals, either drug levels through serum, through dried blood spot, and even through hair levels now. I think Monica Gandhi has a new way to do that. I'm going to get to that in a question, Zoe. So, so we know that the more adherent participants were to Truvada, the more likely they were to have protection. So in some of the studies where they had transmission occur, they actually identified, I think it was in the IPREC study, the patients that had new infections almost all had undetectable or very low drug levels at the time of transmission. So we know that PrEP is very effective, but according to the CDC, presented at the Conference on Retroviral and Opportunistic Infections in 2018, we can see that, you know, there is a minority of individuals who are actually receiving it that would benefit. So again, a push to really look at ways to engage our minority populations where there may be greater mistrust of PrEP. We've struggled to get our African-American individuals on PrEP. They may feel like they can't access it because of insurance, and we'll talk about that. But in general, we need to get more uptake among minority populations so that we do not increase the disparity in minority populations compared to their non-minority counterparts. So introducing PrEP, it can be done in many ways. And I think one of the challenges many people will talk about is, how do I find out who needs PrEP? And so there are strategies that include the things that are done in the waiting room or before the patient, before the provider comes into the room, that include risk assessment, sexual practices. So the straightforward stuff, like how many partners have you had in the last 6 months? Do you have sex with men, women, or both? Are you having vaginal, anal, or oral sex? Do you think you're at risk for HIV? And there are many standard tools out there, and I'm sure the Maytech has some tools they can share. I know Gilead has tools they will share, but there are many out there, and that's a nice way to do it because that takes away the burden of having to have a conversation with everybody. You might be able to do some pre-screening. But introducing PrEP does include a conversation about sexual practices. So you might not screen all your patients for their sexual practices in a conversation, but once you get to we're doing PrEP, I think it's a helpful thing because part of introducing PrEP includes a comprehensive risk reduction counseling strategy. We do want this to be a part of a package and not just, here, take this pill and you don't have to worry about using condoms, you don't have to worry about anything else, because if somebody is taking PrEP and they're not using condoms, then we hope they also are decreasing the number of partners they're having so that they're not developing more STIs or other consequences of unprotected sex. It's also helpful to talk to individuals about how they're going to talk to their partner, if they're going to talk to their partner, and coming up with a plan. So one of the things about PrEP that's nice is that you're going to have regular contact with individuals. And so over time, hopefully we see lower risk occurring rather than higher risk. And I put this slide up just because I think it's important to, again, remember that women have anal sex. I'm not going to read all of this to you. You will get a copy of the slides, but I think we can't forget that women who do have anal sex, and particularly women who are having transactional sex, are likely to have engaged in anal sex. And when women who do have anal sex, most are not using condoms. So that is an important risk factor because of the increased risk in transmission. So our target risk groups include individuals who are HIV positive, men who have sex with men where the partner is either positive or unknown. Now this is a little bit of a personal decision for an individual. So if their partner's positive and undetectable, they may want PrEP still because of it makes them feel more confident. It makes them feel more secure in their relationship. Maybe they have other partners and they don't want to talk about that with you or while their partner's in the room, if they came with their partner. So if I have an individual whose partner's positive and the negative partner is interested in PrEP, I always am comfortable prescribing it because I don't know what's happening. And I know that there are a number of reasons why this is still a good thing. It may be that they aren't confident that the partner's taking their medicine all the time. And then kind of across the board, anyone with a recent STI, anyone with multiple partners, anyone with inconsistent condom use. And then I think the thing that's important to remember is this area of high HIV prevalence. So I've done some talks in Virginia and Washington, D.C. area where the HIV prevalence is super high. And so I think it's important to know what community you're serving and what's the prevalence of that community. And it's probably not the prevalence of Hamilton County, but it's probably the prevalence of a smaller portion of that. And if that's a high prevalence HIV area, then getting PrEP to that community as a more broad sweep is a great HIV prevention option. Similarly, among injection drug users, just all injection drug users would benefit from PrEP. And injection drug users may be getting HIV not from sharing needles, but actually from having sex with somebody that has HIV. And in fact, we've seen that happen not infrequently, where it's other behaviors that are leading to HIV transmission within a population. So among people who inject drugs, then also are having sex with people who are also injecting drugs or also having other risk behavior. So pretty much everybody on the page is a good candidate for PrEP. And then the screening and the follow-up is pretty straightforward. Again, baseline HIV testing for everyone, that is an absolute. That's the only absolute on this slide. Repeat HIV testing is recommended every 3 months. I will move that to every 3 to 4 months, depending on the individual and the situation. Sometimes it might get pushed out to 6 months, but the recommendation is 3 months. I think at baseline, it's appropriate to get STI testing, as well as including syphilis testing. We recommend hepatitis B testing, or at least knowing someone's hepatitis B status. And the reason for that is that Truvada and Descovy do treat active hepatitis B. So if somebody has hepatitis B and they're interested in PrEP, that's fine. They just need to know that starting and stopping the Truvada may cause a flare in hepatitis B if they have it. So if they've been vaccinated as a youth, that's enough. If you want to just get an antigen and make sure they don't have active hepatitis B, that's appropriate. You could do both the antigen and antibody, because honestly, a lot of these patients would benefit from vaccine if they don't have antibody protection. So we do both. We do a surface antibody and a surface antigen. And then we get a baseline renal function. And so the renal function we repeat at least every 6 months. So at the follow-up, you get repeat HIV testing, STI testing, and kidney function. So, and then also assessing adherence and side effects, as well as client-centered counseling. I'll tell you that from a practical standpoint, I get the creatinine when I'm doing the HIV test. I don't try and do every 3 months for one and every 6 months for another, because most of my PrEP patients are not quite that consistent with being exactly on time, and I'd rather make sure to get the creatinine than potentially not have screened it. So when you start somebody on Truvada for any kind of PrEP, I think it's important to think about startup syndrome. You can have a mild headache, nausea, flatulence, or gas. And those are the 3 things that I really talk about. So the startup syndrome is something that is not uncommon, and it typically only lasts for about 5 days. So I encourage patients to expect it and then take the medicine through that, because if they stop it, it's just going to start over again. But if they take it, and I encourage them to take their medicine in the evening, take it with some food. As their body gets used to it, they may not need to continue to do that. And the proportion of people who get startup syndrome is still less than 20%. It's probably more like 5 to 10%. But if they are aware that it might happen, that usually helps mitigate some of the stopping because it made him feel funny. The other two concerns with Truvada specifically are a reported decrease in bone mineral density. This is reversible, as well as the potential for renal toxicity. I'll tell you that we've not seen any type of clinical complications from Truvada for PrEP in the bones, in bone mineral density, because again, most of the individuals who are taking PrEP are young, healthy individuals that don't have reasons to be having problems with their bones. So they've got nice, strong bones to start with. And it's not like a major, major drop in bone density. It's a slight drop. And then the renal toxicity, again, I have not seen this be a problem, but this is where people are leaning towards other options. So Descovy, which is Tenofovir, Alafenamide, and emtricitabine, we know is a new version of the same medication, and it works for HIV treatment. Does it work for prevention? And so the reason that this was a question is because the drug levels are different. So Tenofovir disoproxil fumarate, the old version, has less plasma stability. It also gets into the renal tubular cell more, which is why there's more toxicity. But we know that it gets into the GI tract. And so there was a question of, will there be enough drug to lead to a preventive effect? Because TAF has more in the plasma and gets more intracellularly. So it's a smaller pill, it's the prodrug. Anyways, they go into different compartments is the kind of the point here. So you have lower plasma levels in TAF because it's more intracellular. And the good news is they had the Discover trial where recruited over 5,000 men or sex with men and transgender women. They compared this as a randomized controlled, double-blind, randomized controlled trial that was double-blind and placebo-controlled, looking at a non-inferiority outcome of Descovy versus Truvada. It was 96 weeks of follow-up with an open label extension for 96 weeks. We participated in this, and two of our subjects have their final visit this week. So the 96-week open label is now over. And the good news is it was shown to be non-inferior. And so it has been approved for treatment, for prevention. Now, as far as is it better, I think I dropped that slide. I should have put it in. There's a slide that compares the difference between Truvada and Descovy. And there are benefits of Descovy. You don't have to worry as much about the renal function, although I have yet to really worry about the renal function in most of my young men. There is no difference in recommending of monitoring the renal function. So if Descovy said the package insert said you didn't need to monitor renal function, I think that would be an advantage. But the real concern from advocates across the globe is that Truvada is safe. And as it comes out to a generic version in this month, it's going to be difficult to justify being on the Descovy version if you don't have a good reason. The benefits for Descovy do not outweigh the benefits of Truvada. So there's also a potential for some weight gain with Descovy that is starting to emerge. So I use Descovy in individuals that have or maybe older individuals that have an underlying renal problem. Maybe they've got hypertension and they already have a slight compromise in their creatinine clearance. And then I think Descovy is a great option. For somebody who's really worried about the side effects of Truvada, I would use Descovy, but in general, I do recommend Truvada still as my primary drug. I can't justify the difference in cost to the patient or to the system at this point. And I'm just glad we have options. The other thing that's important to know is that Descovy has only been approved for men who have sex with men and transgender women. So we don't have the data yet for heterosexual women. So we're leaving, and heterosexual men for that matter. So we've left a significant portion of the at-risk individuals out of the indication and the testing, although they're doing the testing for women currently. So there are other good options that are under investigation that include implant or injectables, implants, douches, and on demand. So trying to make sure we have plenty of time. Okay, so Cabotegravir is an integrase strand inhibitor. So it's in the same class as Dolutegravir, Bictegravir, Raltegravir, and Elvitegravir. So Cabotegravir has not been approved for treatment. It's been recommended for treatment as a long-acting injectable, but the FDA has been waiting on that. And then, oh, good point, Willie. I'll mention that in a second. But there have been delays, I think, because of production concerns. So the benefit of Cabotegravir is that it has a long half-life. And so 40 days, even when given orally, and then it can also be given as a injection. So we can use this as a prevention option in every 8 week. It's even been looked at every 12 week. So it's kind of like getting a depot shot for women. So there were 2 studies, HPTN 083 and 084, that are the phase 2b/3 studies that are looking at the use of Cabotegravir long-acting injectable for PrEP in men who have sex with men and transgender women. That's 083, and then cisgender women is 084. And so the very exciting, oh wait, before I get to the exciting news. So the long-acting agent, so we've got these great drugs, but is there some bad news that goes with the good news? So the good news is they're easy to give, because you don't have to take it every day. The concern is that there is this tail. So with the long half-life, you can't remove that drug. And so there is this zone of resistance that's described in the red here, where someone has enough drug in their system that if they got exposed and infected with HIV, they would likely develop resistance to that drug. And we don't know if that crosses with other integrase inhibitors, which is a really important type of HIV medication. So if they have this subtherapeutic drug level, are we putting them at risk for developing resistance to HIV if they get exposed? So the point of that is that when they design the study, I don't think they actually realized how long the tail was going to be. So they monitored drug levels, and they found that sometimes the tail was even measurable or the drug levels were measured at 48 weeks. So they had modified the study protocol so that after people stopped the long-acting injectable, they then had to take Truvada for PrEP for 48 weeks. So they had a second form of coverage. So it's a long-winded say is we don't know what to do about the tail, but right now people are recommending a second agent. If somebody stops wanting the injectable medicine, we want to continue to give them some sort of protection so that they, while that tail washes out. So the good news is that at IAS this year, the summer, they presented results from the HPTN 083, which is for the one for men who have sex with men and transgender women, and it showed it outperformed daily Truvada, which was very exciting. There were less new infections. It was well tolerated. They had less drop off, and it really was very exciting to see these results finally come out and be reported. So I haven't seen that they've submitted to the FDA yet, but I think they have. So with injectable PrEP, there are just some questions. This isn't a poll, but how can we ensure adherence to these type of injections? We know that nearly half of women who are on injectable contraception discontinue annually. And then once we start somebody on long-acting injectable, how do we counsel them about how long they're protected, how long that we need to worry about low levels of drug? What about around conception? So this the 084 study was halted for a period of time because there was a moment where we thought, or there were reports of integrase inhibitor, not with Cabotegravir, but with Dolutegravir being associated with neural tube defects. And so women who were getting Cabotegravir for PrEP are also potentially women who are of childbearing age. And so they had to halt the study, get more information, and at least talk with participants about their potential risk. So the good news is they've moved forward, and the risk is not felt to be greater than someone who's not on Cabotegravir, but we have to consider these things every time we look at a new medication, that there are other consequential considerations. Do we think that this oral PrEP is an acceptable strategy to keep people safe? So these are just questions that have been raised that I think are important to consider. I'm going to answer Willie's question. So the question is about HIV testing for the for transforming reentry service. And the question is, should people be tested for hepatitis C before starting PrEP? And that's a great question. So the answer is yes, that is recommended to do a hepatitis C test. The reason is not because there's any relationship with HIV PrEP or PrEP for HIV and hepatitis C. It is recommended because there is a concern of a greater risk of hepatitis C among the individuals seeking HIV prevention. So it is not part of our standard protocol, but we're doing a lot of hep C testing outside. So many of our patients have already been hep C tested. I don't think it's a bad idea. I think that we know hepatitis C is infrequently passed through sexual transmission, but it is definitely can be passed through sexual transmission if there is a high-risk behavior where there is blood or broken tissue and I guess kind of rougher sex. So if I were working with the corrections population, I would want them to be tested for HIV and hep C because it's the recommendations for hep C testing in corrections are all individuals in the corrections should get tested for hep C. So if they didn't get tested, and even if they did on their leaving, I think that that's a good strategy. And now the U.S. Preventive Health Services has recommended hepatitis C testing for all adults, similar to the HIV test, that everybody gets tested at least once. So thank you for that question. Another drug that has been submitted for at least the Europeans is this Dapivirine ring. This is like the NuvaRing, for those of you who are at all in female contraception, where it's a ring that fits around a woman's cervix. It has medication in the ring, and it is deployed over 30 days. You change it out every month. And this was shown to have some reduction in HIV transmission in 2 different studies that are listed here, the Aspire and the Ring study. Certainly adherence was a challenge. Even with these easy to use rings, they did have lower rates of adherence than I think they ever imagined. And at the same time, they had a reduction. So these are moving forward. They are exciting, they're newer, they're something different than a pill, and there's something specifically for women. Now, here's a picture of the Dapivirine ring. You can see women have to be, comfortable putting their finger in their vagina. The nice thing is that it's long acting. It's got a very strong safety profile. It doesn't seem to interact with other medications, especially contraception. It's not a drug that we're using for treatment, so we're not worried about resistance. And then it's also very discreet, so women don't have to share it with their partner. The partner doesn't need to know. The partner won't feel it. It doesn't interrupt sex, exercise, or other activities. And it's also easy to store and to manufacture. So it's got a lot of advantages that are important to not only use, but build upon. So there's been talk of having a Dapivirine ring or other ring that also includes a contraception at the same time. So you can have a woman have both protection against unplanned pregnancy and HIV. So tools for PrEP. So how do you get people on one of these great tools or one of these great options, these biomedical prevention options? So you've got Truvada, you've got Descovy. Very soon you're going to have long-acting Cabotegravir. Also very soon you may have Dapivirine. So I think there are things that we need to think about as providers of how to get PrEP out there. One of the things that we have used is a smart set, and I'll show you an example of that. It's just a nice, easy way to have all the associated orders in one place for providers, particularly those that are not doing this often. It's a tool in the electronic health record. We've also done things like TelePrep, InstaPrep, and pop-up prep, which are really just novel strategies to find people that are eligible for PrEP and bring it to them. So one of our nurse practitioners has done PrEP at health fairs. She's done it at Pride, and she's done it at, I don't know if she did it at Claw, but she was going to do it at Claw when the next time they have Claw. They've been invited to have a little stand where a rapid HIV test is done, and then we've got our remote into our electronic health record, and she can prescribe medication on the spot. Another tool that we have in Ohio that's fantastic is our PrEP navigators. Adam is the head of this program, and I found Leah online as the PrEP navigator for the Cincinnati area. And we also, as a result of our PrEP navigator program that this is sponsored by the Ohio Department of Health, we have the POPPY program, where individuals who don't have health insurance can get the same type of medical care and treatment for other related care. So they can get their office visit for PrEP, as well as their testing diagnostics covered by the POPPY program. And then also the PrEP navigators can help assist getting medication for someone who is uninsured. So our PrEP navigators are great. We have one at our institution that works for part of Cuyahoga County in our region, as well as one at university. We're looking at things in our pipeline of alerts for high-risk situations. So if somebody is newly diagnosed with syphilis, I think it would be really cool to have a pop-up. Unfortunately, interpreting syphilis tests is not straightforward for any of those of you who do that frequently. But they're just thinking about creative ways to identify patients. And so Willie has another question, that if somebody has hepatitis C, can they take PrEP? And the answer is absolutely yes. There is no drug interaction, and there is no contraindication to hepatitis C infection and taking PrEP. It's only hepatitis B, and even then it's not a contraindication. It's more of a caution that we wouldn't want somebody to stop and start. We want them to continue on treatment consistently. So this is a picture of our smart set. Any of these items, the diagnosis codes, the labs in clinic, or the future orders are drop-down menus that you can just click, 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 and go through your orders very easily. And now we can actually create even a quicker way to do this if there's something that you always order together. But one of the things that I think is really important to remember to do if you have the ability is to put orders in advance, so that if, when I see somebody, I'm starting them on medication, I put in a standing order for their HIV test for the year. So it's every 12 weeks, a standing order of 4 for a year, so that I'm not trying to track them down and make sure that they've got an order in place. They can just say, come back, get your lab. Our PrEP navigator can say, just go to the lab. And then we can also do things like TelePrep, where we're doing this by video and not having to bring people in person each time. I believe both the hepatitis A and B vaccine are covered by POPPY. That's a question on the chat. I don't know about the flu vaccine, but Adam might know. And Adam is muted, so he won't, oh, he's unmuted.
All of those are actually covered by the POPPY program.
Excellent. Thanks for asking it, Shanna. So PrEP is covered. It's covered by Medicaid, it's covered by insurance. We've got the uninsured program, which is now, it's not through Gilead, it's actually through like Get Me PrEP or Get Prep Me, I can't remember. I just found the website again yesterday, but there is an application process. It's pretty streamlined. And again, that's where your PrEP navigator or social worker may be able to help you do that. If you don't have one of those, then I would contact Adam and Leah. It is something that out of pocket is fairly pricey. The generic is supposed to be coming in September, so we are almost done with September, so I haven't seen it. I did hear that the first year, it's only going to be available through one generic provider, Teva, and so the savings may not be as much as what we would expect to see by being generic, but I think that is just for the first year. So it will be interesting to see what happens with Truvada versus Descovy approval for like the prior auth procedure for patients when Truvada becomes available generically. So just a couple of questions that have been asked of me in the past when I do these talks. And so I bring them here so I remember to mention them. So what should happen if somebody misses follow-up of their scheduled HIV testing? Or prescriptions. So we tell people, we want you to come in every 3 months. What I do is I prescribe 1 month plus 3 refills, which is really 4 months of medication. And then I'm going to get a refill request at the point that they're due for their next one, which is my reminder to say, let me check to see if this person got their HIV test. Let me see if they're scheduled to come in. And if they aren't, then I'm going to reach out or have someone reach out from my office to encourage that individual to get in for their lab testing, as well as get maybe STI screening, etc. Zoe's asking about point of care rapid tests as proof of HIV testing. I would say yes, I do accept that. I think that the point of care rapid tests do not have the same sensitivity and specificity as the lab-based tests, but they're still very good. I think if you're concerned about their risk when they're doing a rapid test, I might do a repeat sooner than I would normally do. So some of the time we might do a repeat HIV test in less than a month rather than waiting for 3 months. Why would someone not be a candidate for PrEP? I don't have any good reason. Maybe if they're a dialysis patient, but I would even consider using Descovy in that individual, or now we'll have Cabotegravir where we don't have to worry about their renal function. There isn't a good answer. So I don't think there are people who are not good candidates for PrEP, especially now that we have multiple options. It's been posed to me, do I think that PrEP should be available without a prescription? I think at this point, I'm not comfortable with that because I would be concerned about people taking it without knowing their HIV status. I think the benefit of having it still be a prescription is that providers are able to ensure that an individual is HIV negative before they start taking it, and hopefully are monitoring that they are maintaining a negative HIV and they're maintaining their medication, which will keep them HIV negative, which makes PrEP safe. I don't like the idea of somebody being able to take it and then, and that's actually one of the downsides of giving a 3-month supply or a 4-month supply, is that somebody, once they have the prescription, they could stop taking PrEP, they could become infected and then feel like, oh, now I've got risk and now I'm going to restart PrEP, but in fact, they've already developed HIV. That's a potential risk, and that's something to talk with patients about, that if they stop, they ought to get retested for HIV before restarting. Not if they're stopping for like a day, but if they stop for a month or 2. And then finally, what about adolescents? And the good news is we now have approval for not actually an age range. It's interesting, they approved it based on weight. So a person needs to be 35 kilograms or greater to be able to be prescribed Truvada, which allows us to prescribe to adolescents as long as they are, I think, 70 pounds. PrEPception is something that is supported by CDC. There's a clinical fact sheet. I hope that still works. And it's the idea of having different couples have more comfort with the idea of getting the female partner pregnant. I have done this for one of my patients whose he and his male partner were kind of the parent, wanted to be the biological parent for a female couple. And so the female took PrEP prior to getting pregnant with a surrogate, not a surrogate. All I can think of is a turkey baster. But anyways, it can be used to prevent HIV acquisition for an HIV negative partner. Ideally, you start this a month before starting to attempt conception, and then ideally you continue it for a month after the last conception attempt. I'm not sure that there's any justification for that full month, but that follows in the idea of how long you take PEP. And the benefit of PrEP during pregnancy, again, is that comfort, and we know it's safe. So in the Partners PrEP study, there were 431 women who got pregnant during the study, and they found no difference between the groups, whether they were placebo to tenofovir only or tenofovir plus FTC, which is either tenofovir, which is Viriad, or TDF FTC, which is Truvada. And here they saw no differences in rates of conception, pregnancy loss, preterm, births, birth defects, or growth at 12 months. So it's very effective, very safe. And we also know this because we use it in treatment. So there are some challenges going forward in PrEP that are more from a scientific challenge than some of the other challenges we talked about. But with the current options we have for HIV prevention being so highly effective, how are we going to measure effectiveness when you have very few new HIV exposures in these clinical trials? And head-to-head comparison with the two effective agents is really, it's a limiting factor. You have to make these very, very large studies. So I don't have an answer for that. The good news is there are other people who are smarter than me thinking about this more often. But there are study designs where they may be looking at multiple options all at the same time, which allows for more information without having to do these huge studies for just two treatment options. I just want to introduce a few thoughts of ideas that are important to consider. So right now, we don't have a prevention method that is really behaviorally congruent. So we know that rectal douching is a common practice prior to anal intercourse that's been acknowledged in many areas. And so couldn't we use this as a way to introduce a prevention option? And so in fact, this DREAM study is a phase 1 study that looks at the colorectal. It's a phase 1 dose finding study of tenofovir douches and compares it to oral tenofovir in a gel. And what we see is that we get very high levels of tenofovir when a douche is used, both at 3 hours immediately following the douche as well as 24 hours later. So very high drug levels, very exciting and promising. And this would be a on-demand type of prevention option. And it's been used in non-human primates. They're comparing it in this HTP and DREAM study, where they're looking at oral tenofovir versus a tenofovir douche in non-human primates. And what we see there also is very high rates of protection in those that get the douching. These implantable devices, think Nexplanon, think Norplant, are also exciting. One of the benefits of these is that if you have your Cabotegravir in this, instead of having that long tail, you remove the device and then you don't have to worry about the tail afterwards. So having it be reversible with removal is good for a number of reasons, one of which is the drug level that may be left over afterwards. So there are a couple of different drugs that are in development for this, including the new version of tenofovir, the TAF, Cabotegravir, and I can't remember, EFDA doesn't have a name. I think it is just EFDA. There's also interest in new delivery devices. So these microneedles are an area where it could be essentially delivering drug through one of the three things up at the top, a roller, a pen, or a patch. And rather than just being transdermal, it actually makes a little tiny puncture so that the medication gets more directly into the system. And this allows for better absorption of medications that don't necessarily absorb through just a transdermal connection. And here's a histological slide of what this microneedle does to the skin, and you can imagine how that may facilitate better drug levels. And then the last thing I'm going to mention is about prevention options that is exciting are these broadly neutralizing antibodies. So for many years, we didn't think that people with HIV developed any antibody response. And then they discovered actually like in the late 90s that in fact there were a lot of antibodies that were being developed, and some of those they are now looking at as treatment options, as infusions. And so one of the things that it first came out, we found one, then we found two, and they're like, well, let's give multiple. So the AMP studies are studies looking at antibody-mediated protection, I think is what AMP stands for, where they're really looking to see, does this provide any antibody response, let alone protection? So these are still very early. There are a lot of phase 1 studies, but this is something to keep your eye out for as a future in HIV prevention. All right, our last poll is, this is a patient, and so 2 different patients, but the question is related to either scenario. So the first is that you have a patient who presents the emergency department following sexual assault. Wait, Adam, you got to move this for a second. Presents to the emergency department following sexual assault by an unknown assailant. The second scenario is the patient presents to the emergency department and just learned that his partner is HIV positive and the condom broke or fell off or some other scenario. And so the question is, what would you do now? And now, Adam, if you want to put the slide up, the poll.
We've got the poll up. Thank you.
Awesome.
Sorry about I jumped the gun on that.
I misled you. It's okay.
We're getting some results in. We'll just give it another maybe 20 seconds or so.
Okay. I promise I'm almost done.
And while we're waiting on the results, I just want to give you a real shout out. I've been monitoring a lot of our sessions all this week, and you're our first presenter who was able to talk and monitor the Q&A without my help. So kudos to you.
Well, thank you. And so Leanne says, yes, I can. Oh, can you have more than one answer? Not to this one. Sorry.
Okay, so I'm going to end the poll and share the results. Hopefully everybody can see that.
All right. So I guess there is more than one answer. So this person, you might want to treat them with ceftriaxone and azithro. So I should have said, yes, you can. But the answer that I was looking for, read my mind, is HIV test now, and if they're negative, start Truvada and Cabotegravir. And so why did I say that? You guys must know, because most of you got it right. And the person who didn't get it right probably wanted to do both. So post-exposure prophylaxis is something that we've been using for many years in the clinical scenario for occupational exposures like needle sticks. And it's been more recent that we've really encouraged individuals to consider this and provide support for this in a non-occupational exposure. So sexual exposure that might be, by consensual sex, where there's maybe an unknown exposure and then suddenly you find out, or a non-consensual, like the situation of rape or assault. And then also in non-occupational, like injection drug use. So the guidelines are the same regardless of whether it's for an occupational exposure or non-occupational, and that is to take the medication to start within 72 hours of exposure and to continue for 28 days. The ideal situation is the sooner the better, like any kind of post-exposure prophylaxis. If it's more than 72 hours, it's really felt to not be beneficial. I think that if somebody takes it for 7 days, they probably get the majority of benefit from the medication. There's not really good data, and we will never get good data on why we use 28 days. That's just how the study was designed way back when they did this in monkeys, and I don't foresee that it will ever change. But we know that the virus can't live in a person's system for that long. So if a person were to take post-exposure prophylaxis for a week, they still may have a benefit. I'm not encouraging 1 week. I'm just saying when patients stop, that if they've taken it for a period of time, they're going to get benefit. The longer they take it, the more benefit they have. The recommended regimen is typically Truvada plus either Raltegravir or Dolutegravir. Honestly, any HIV combination is effective. There are differences in which ones we would suggest based on tolerance as well as in drug interactions. And so this Truvada plus Raltegravir, Truvada plus Dolutegravir, Tivicay, is known to have essentially no drug interactions as well as very, very well tolerated. But it's important, again, with post-exposure prophylaxis to conduct a baseline HIV test. And that's not so that because there's a risk to giving PrEP to somebody who has HIV, but because we need to be able to tell this individual if they were HIV negative or if they already had HIV when they started PrEP. If they're positive, they could still get PrEP. So in fact, in our emergency departments, we don't always have a rapid test available because our turnaround time is so quick that the lab is really discouraged using rapid testing. And so some of our satellite hospitals, they may need to, or satellite emergency departments may use a lab draw and the person may leave before the HIV test is completed, and that's fine. They can still start PrEP because it's safe if you have HIV. It's an HIV treatment regimen. And then like any bloodborne exposure, we would want to be testing and potentially providing post-exposure prophylaxis for other things like STIs, pregnancy, and maybe looking for hepatitis, depending on what the exposure is. So when somebody gets PrEP, and I mentioned this earlier as a tool in someone who has high risk, using it as a response to an acute exposure, it may be a way to start somebody on PrEP where you're worried about their risk right now, but you really want to get them started. So the PEP to PrEP transition is a way to take somebody who maybe hadn't thought about PrEP and recognize that rather than doing this post-exposure prophylaxis, let's give you pre-exposure prophylaxis. So somebody that came in, a second scenario particularly, where it was somebody that was having sex with an HIV positive partner, they might continue to have sex with that same partner, or they might have other partners who have risk. And so starting with PEP for 28 days and then transitioning to PrEP after 28 days is a really awesome way to get high-risk individuals onto prevention. Now, that transition is what we call a data-free zone, where we don't know what the best thing to do is. But one of the ways that a lot of the experts have handled this is to look at doing a combined 4th generation or 5th generation antibody antigen test at week 4 while they're still on PEP. And then if it is still negative, then to just transition them before their medications, before they finish their medications, and then de-escalate to Truvada. Now, the other thing that I would say, it's a nuance, is that we prescribe 28 days. Reality is the pharmacy is not going to take 2 pills out of the bottle. So these medications come as 30-day supplies. So most patients actually get 30 days of medication. And I would not, if you get asked that question, 28 versus 30, I would certainly provide somebody a 1-month supply, which is 30 days. And that's the way it's better from a pharmacy standpoint to dispense. So that was a lot of information. I really appreciate you all taking the time at dinner time on a Thursday evening when it's beautiful here to sit and listen to this talk. I think that we've got a few things. One, we know that Tenofovir emtricitabine or Truvada for PrEP has set a very high bar for preventive effectiveness. We've got some long-acting preparations that are solving some challenges that are hopefully going to be available very, very soon. They will present new challenges also. We've got a ripe future with new possibilities in implants and antibody-mediated protections and other interesting ways to deliver PrEP. We need more on-demand options, and more is better. So I think that the more options we have for patients, the more likely we are to engage patients, because One pill once a day is not for everybody, and we have to recognize that. And I have to acknowledge Rustin Zamarati, Dr. Landowitz, and Dr. Hillier for sharing their slides and their time with me. Rustin is a current second-year physician resident in New York, but he worked with me during his 5 years of getting his MD and his MPH. Dr. Landowitz and Hillier are excellent colleagues, so appreciate their contributions. And I thought my last slide had my contact information. It doesn't. So I can add that before we circulate the slides.
And we will have slides available to everyone, and we'll make sure that you get Dr. Avery's contact information. I have a personal question for you, or a question from me personally.
Yes.
This is Adam. I wonder, I know that at Metro Health, you all have a PAPI program.
Yes.
And I think Kareem works in that program or heads it up.
Hakeem.
I'm sorry, Hakeem, sorry. I wonder if you can talk about what your experience has been like with the PAPI program.
So it's been a little challenging. I think it's been a great program in theory. I've not had to be directly involved with some of the back and forth logistics, but being a large hospital system has made it sometimes challenging to have what we do line up with the PAPI program. And so I know that's when I've been involved, when there's been, I'm trying to remember if it was the HPV vaccine or some other vaccine that wasn't covered at the time. And so the patient got that, but then didn't, it wasn't covered. And I think even treatment might have been an issue because of the assumption of being able to get free treatment through the state. But as the hospital system, we don't have that. And so I could be wrong on that. Adam, you're probably more familiar with that. But I have to say, having a PrEP navigator has been phenomenal. Akeem and Demai are up here in the greater Cleveland area, and I think both are out there promoting PrEP. I talk about them as being your point person to get anybody from I have a question or I'm thinking about it all the way to sign me up and then make sure I come back in a few months, as a resource for us. Akeem has been great to follow up with patients in that, I want somebody to call this guy or this person in 3 weeks or in 3 days. What's your experience been?
That's great to hear. I agree. I mean, there has been some startup issues, like you talked about, with working with a large hospital system and trying to get the Ohio Department of Health and whatever large hospital system it is to kind of meet in the middle and agree to, work together, kind of thing. But as a follow-up question to that, do you see any difference in the patients that you have who are your PrEP patients who had contact with PrEP navigators versus those who didn't have contact with PrEP navigators?
I don't know that I can answer that, because the way I think it would be interesting to look at, because we've done, even before we had Akeem as a PrEP navigator, we were working to increase the capacity of our primary care providers to start PrEP. And so the patients that are there, we're more kind of saying, hey, by the way, we have this extra support person that can help you with your patient, and let me introduce you, and then here's the support. Whereas during some of our designated times, Akeem's there, so he will try and meet with any of the patients that are coming into our PrEP clinic, or spend some time at the health department, where our NPs who are at Metro also go to provide the services at the health department. So I'm not sure I can answer that question very well.
Okay, thank you. Well, it looks like we've got 2 questions out there in the Q&A.
Nice.
I'll let you handle those.
All right, so Willie is asking about talking about U equals U when taking PEP. So I think I know what you're talking about. So the, it's actually, not sure so when somebody is taking PrEP, I guess there's two scenarios I guess I'm thinking about. One is if a partner is HIV positive and undetectable, is PrEP needed? Is one way to, I think, ask that question. And so the question that I would say is probably not. If they're undetectable, they're untransmittable, so I wouldn't pursue PrEP. Most of the time when this happens, we don't know whether or not the individual is undetectable, that is the individual of concern that had HIV. So the scenarios that we get are somebody comes in the middle of the night or on the weekend saying, I just found out the person I was with yesterday is HIV positive. They say they're undetectable, but I'm afraid. And so I'm treating the person in front of me. I don't have a way to verify that the individual they were with is on medication, is taking their medication, is undetectable. So I'm going to take care of that individual who has been now exposed with PrEP. On the other side, I had a situation, and I think this is kind of a corollary of that, where somebody is on PrEP, they're taking their PrEP consistently, and then they find out the partner that they've been with and having unprotected sex with finds out that they are newly diagnosed with HIV. And so the person who is on PrEP, this truly happened. He came to me and said, do I need to do anything else? Do I need to go on to PrEP? Do I need to get tested? And we had a quick conversation. He'd been very adherent to his medication. And I said, no, this is why you're on PrEP. And he got his retest at the recommended interval at whenever 3 months or 4 months was up for him, and he has stayed negative, and his partner has gotten into care and on treatment, and he stays on PrEP. He doesn't want to stop taking it for now, even though he's in a long-term relationship. It's part of his routine. So I hope that answered your question, Willie. If it didn't, please add more. And then Zoe asked about the hubbub of doxy as a form of PrEP for STIs. And do I think it's appropriate or has a future? Doxy it's not a PrEP, it's a PrEP for STIs, as you said. So the idea is that for individuals who are high risk for STIs, if they took daily PrEP or daily doxy, or even a post-exposure doxy, the frequency of STIs afterwards is actually exceedingly low. I think it's got promise. I think it's a little scary. And so it's not something we're using here. Jeff Klausner, who is in LA, is the one who's done all the work on that. And I think in a place like Los Angeles, if I were a gay man in LA, I'd be considering taking doxy. I think it depends on the population and where somebody is and their personal behaviors. So really making that a client-centered decision. But I do think it's something that has a future, but I don't know what its future is. So thanks for those great questions.
Thank you, Dr. Avery. That was a great presentation. And I'm sure that everybody who participated was very willing to miss dinner or watch dinner while they were, or eat dinner while they were watching you present. It doesn't look like we have any questions right now. We'll give it maybe a moment to see if anybody has any questions. Other than that, I want to give you the last word and see if you have anything to add.
Oh, I had prepared a last word.
Well, maybe the last word.
Test everybody and don't forget to offer PrEP.
Good sound advice. Thank you, Dr. Avery, for participating in CaraConference 2020. And real quick, before we end the session, I want to plug that in Cincinnati, we have a POPPY program. It's through CaraCol. If you have anybody who wants to get on PrEP and they have any challenges when it comes to costs to access PrEP, we can help with that. And real quick, tomorrow is our final session. And Here we go. Hi. Tomorrow is our final session for CaraConference, and it'll be a panel discussion that starts tomorrow at noon. All of our sessions are recorded, so if you can't make it, you will get access to all of them. Next week, we'll send out an email with all the links. But tomorrow, the panel session is on racism as a public health crisis, and we have CaraCol's own Tavon Hall, who will be facilitating the program. And one of the panelists is Victoria Parks, who is a Hamilton County commissioner who was able to push through the local ordinance that deals with racism as a public health. So if you can join us, please do. And again, thank you to everybody for your participation this evening. And thank you to Dr. Avery for a great presentation. Have a great evening, everyone.